If you're getting ready for an exam, the COPD questions are difficult. That's because they're normally intertwined with other respiratory conditions like pneumonia and congestive heart failure. But if you can watch this video, you will never miss a COPD question again. Let's get started. COPD is one of the most common conditions we're going to encounter. And to truly understand COPD, we're going to need to review what normal looks like. So the cells of the body produce CO2 and they end up accumulating in the body. And there's sensors on our brain and our brainstem. And when we have too much CO2, well, it triggers the body to breathe. The brain starts sending a signal down to the diaphragm, and it gets louder and louder. And the more CO2 that accumulates, the louder the signal. You guys can feel this by just taking your breath and holding it. As you hold your breath, the urge to breathe becomes stronger and stronger. Well, that's the brain saying the CO2 is getting higher and higher in here. And if you didn't know any better, it's easy to assume that the respiratory system is driven by oxygen levels, but in a healthy adult, it's actually driven by the CO2 levels. So as that signal works its way down to the diaphragm, well, the diaphragm contracts and draws in fresh oxygen for the blood, and CO2 leaves the blood and goes in the alveoli and eventually in the air that we exhale. And that's how our body gets oxygen and removes the CO2. And understanding this process is going to help us understand COPD. Now, another thing we need to understand is inspiratory and expiratory times and volumes. A normal breath for a person is 5 to 7 milliliters per kilogram of ideal body weight. But just for numbers' sake, we're going to use this generic number of 500, but I do want to emphasize one thing. If you're a provider and you're ever using a transport vent, don't just go off that generic 500 milliliters, because for some patients that might not be enough, and for a lot of patients that is too much. So understanding tidal volume is critical in understanding COPD. But it's not just the amount of air we're breathing in and out, it's the times. So imagine you're going to a concert and the concert hall only holds 500 people and every ticket is sold out. And the doors open and everybody has 1 minute to get to their seat. Imagine the doorways going into that concert hall. They're going to be crowded and there's going to be a lot of pressure because everybody's trying to cram in over that 1 minute. But then when the concert's over, you have 3 minutes to leave. Now, everybody isn't going to be trying to cram through that doorway, so there's less pressure. Well, the same thing happens when we breathe. On average, it takes about 3 times longer to breathe out than it is to breathe in. And this can change based on your respiratory rate, but this is relevant in COPD. Let's go over why. One of the problems with COPD is the inflammation of the bronchioles. Well, when we're breathing air in and all those people are rushing into the concert hall, there's enough pressure to push those bronchioles out. But when we're breathing out, there's less pressure on the bronchioles, and that's where your COPD patients normally have problems. They don't have a problem getting air in. They have more of a problem getting air out. That's the problem with COPD, is it traps air in our lungs. So normally what happens is air travels down the bronchioles, works its way to the alveoli, waits for a red blood cell, and then it's distributed out to the body for the cells to do what the cells do. But not all the air we breathe in is available for exchange. Of that 500 milliliters, only 350 milliliters actually makes it to the alveoli for gas exchange. The other 150 are in structures like the trachea and the bronchioles, places where there's no gas exchange. Let's dig a little deeper into the bronchiole. They're actually lined with 2 different types of cells. There's goblet cells and cilia. The cilia act like little sea anemones, pushing debris and diseases and anything the lungs don't want out. And the goblet cells actually just produce mucus. And the main purpose of this mucus is to capture things that don't belong in the lungs. Now, the bronchioles are surrounded by smooth muscle, and this is important because a lot of our treatments work on this smooth muscle. You see, this smooth muscle responds to the sympathetic nervous system. You remember the alpha 1, beta 1, beta 2? Alpha 1 receptors are found on the arteries. As a matter of fact, a good memory aid is alpha 1 arteries. Beta 1 is found in the beating heart. You have one beating heart, beta 1. And beta 2 is for two breathing lungs, or the smooth muscle on the bronchioles. So medications like albuterol and epinephrine will work directly on the smooth muscle and cause it to relax. Now, the other thing, I was a paramedic for a long time before I really conceptualized this. But the alveoli aren't just for gas exchange, they actually help with exhalation. And they do that because they have these elastic fibers, and you can think of them as rubber bands. As you breathe in, they get stretched out. Now, you can imagine blowing up a balloon and then letting it go. And all the air, because of the high pressure, escapes the balloon. The same thing happens in our alveoli. When we breathe in, we fill them up. And then when we decrease the pressure, well, it's just like letting go of that balloon, and the alveoli actually squeeze and help with ventilation. So they're not just for respiration, they actually help us expel air as well. So now we know what normal looks like. Let's get to the meat and potatoes of COPD. So we have these immune cells. They're called macrophages, right? And I think of them as the Paul Blarts of the immune system. And they ride around whenever they see injury, like the lungs get when somebody smokes, and they release cytokines right into the tissue. Now, normally this is a healthy process. It causes the inflammation that triggers other cells and helps the body heal. But when you're smoking or chronically exposed to irritants, well, the macrophages are constantly putting those cytokines into the cells, and they don't have time to clean out. So what do? Well, they cause inflammation. So you remember the elastic fibers that we talked about with the alveoli? Well, they turn them into kind of stretched out rubber bands. They lose their elasticity. So the alveoli can no longer help in the exhalation process. They also cause inflammation of the bronchioles. So this narrows the passageway, which isn't so much a problem breathing in, it's a problem breathing out, if you think back to the concert analogy that we used. The other thing they do is they cause those goblet cells that produce mucus to go into overdrive. This makes it harder for the cilia to capture any irritants or diseases. This is one of the main reasons COPD patients are prone to respiratory diseases like pneumonia. Their body has a harder time capturing it to remove it from the respiratory tract. Look at the top left of the screen. This is the problem with COPD. So we start getting air in, but due to that constriction and the lack of elasticity in the alveoli, well, the air stays there. So we end up with air trapping. And ultimately, that's what COPD is. It's just trapped air. Our normal tidal volume of 500 that had an alveolar volume of 350 and a dead air space of 150, well, now that dead airspace starts to increase and the alveolar ventilation starts to decrease. Now, this happens early on in COPD, long before the patients start to develop any signs and symptoms. That dead airspace starts slowly inching up while the alveolar ventilation starts slowly inching down. And generally, COPD is diagnosed once that dead airspace reaches about 60%. So what does this cause? Well, if the alveoli have lost their elasticity and they can't get rid of the air in them, well, the CO2 starts to accumulate in the alveoli. The CO2 that's in the blood doesn't really have a place to go. So now these patients start to retain CO2, which decreases the pH and drives up the respiratory rate. Which leads me to a very common misconception. So we talked earlier about how the brain monitors CO2 levels, and that's what gives us our respiratory drive. Well, in COPD patients, they're chronically high in CO2. So the brain says enough with this and starts monitoring the oxygen instead of the CO2. And this is what's caused the hypoxic drive. So it just means that the body's respiratory drive is no longer CO2 driven, it's actually oxygen driven. Now, this led some providers in emergency care to withhold oxygen out of fear that they would wipe out the patient's respiratory drive. Well, in concept, that's understandable, but you would be hard pressed to find a case in an emergency setting where somebody knocked out somebody's respiratory drive because they were administered oxygen. And obviously follow your protocols and talk to your medical director, but I would much rather explain why I gave a hypoxic patient oxygen than worry about something that doesn't really seem to show up in the emergency setting. So far, we've talked about COPD like it's just one condition, but it's actually a spectrum. And unlike our political system, it's not one group on one side and one group on the other side. Almost all of your patients are going to fall somewhere on the spectrum. They might be more to this side or more to this side, but they tend to have a little bit of damage of both. So let's explain why. Chronic bronchitis is due to those goblet cells we talked about earlier just producing way too much mucus, and that starts to clog up the bronchioles. And this is where these patients get the nickname blue bloater. It's because they're chronically hypoxic and they start to develop this bluish tinge. Now, on the other side of the spectrum, we have emphysema patients. Now, emphysema refers more to the damage to the alveoli from those macrophages filling them with cytokines and the alveoli losing that elasticity. Now, as a response, the body improves its oxygen carrying capabilities by producing more red blood cells. And this is where the term pink puffer comes from. Their skin is redder because they have more red blood cells, and the patient breathing out against pursed lips. Now, another thing that makes COPD that much trickier is that a lot of COPD patients have CHF. And that's because COPD can lead to CHF. So how's this start? Well, the right ventricle normally pushes blood through all the pulmonary capillaries, all those little blood vessels around the alveoli, where they can drop off CO2 and pick up oxygen. But as the air starts to trap in those alveoli, well, it starts to pinch off those little tiny blood vessels. This makes it really hard for the right side of the heart to pump that blood through. So, like any other muscle, it's going to start to get enlarged. Now, that could take me down a whole different road because we need to make a video on CHF because that's another one that's difficult. But for today, we're just going to say that right-sided heart failure often leads to left-sided heart failure. So it's not uncommon to find a patient with COPD or CHF, but understanding the difference can help guide that treatment. So what's the COPD patient look like? Well, for starters, our lung sounds are going to have some end expiratory wheezing because we got that bronchial constriction. And then we have that fluid in there from those goblet cells just in overdrive. And if that fluid is just in the alveoli, well, it starts to present as rales or crackles. But if it starts to back up into the bronchioles, well, now we're going to have bronchi. These patients are also going to present with pursed lips. That's something that's a lot more common in your COPD patients than it is your CHF patients. We're going to have lower than normal oxygen levels, but the good news is they respond really well to a little bit of oxygen. And then we have the clubbed fingers. These clubbed fingers take a long time to develop. So if you notice it in your patient, well, it's a good indication they've been dealing with this for a while. And you do this by putting the patient's fingers together. And in a normal adult, you should be able to see a diamond shape right above the nail beds. But if they have the clubbed fingers, you won't. Now be honest, how many of you are looking at your fingers right now? And then we have a pedal edema. That's because the right side is having a hard time pushing that blood through the lungs, and that's going to cause a backup. So if the heart can't completely drain of its blood, well, that blood is going to back up into the venous system. And if a patient is ambulatory at all or can sit up, well, that fluid's going to settle in the lowest spot, which presents as pedal edema. Now, if a patient was supine all the time and bed confined, that would cause sacral edema or edema in the lower back. And it's really just the same thing. It's just the fluid settling in the lowest point in the body. So how do we treat these patients? Now, we're going to be a little conservative with the oxygen. And it's not because of the hypoxic drive or what we talked about earlier. It's actually because it can cause these patients to get acidotic. So while we would normally aim for a pulse ox of 94 to 99, in COPD patients, we're actually going to aim a little lower at 88 to 92. How does oxygen cause acidosis? Well, as these patients' bodies start to fill up with CO2, a lot of it adheres to the red blood cells. But red blood cells like oxygen a lot more than they do CO2. So when we start putting oxygen on this patient, well, that oxygen displaces CO2 that's in the blood. Normally, that wouldn't be a problem. It would find its way to the alveoli where there was a lower concentration of CO2, and we would breathe it out. But in COPD patients, Remember, those alveoli have lost their elasticity. They're just sitting there full of CO2, and the concentration of CO2 in the alveoli is actually higher than the concentration of CO2 in the blood. So that CO2 ends up just staying in the blood. But we can't just withhold oxygen to a hypoxic patient. So what we do is we just lower our target. Instead of that 94 to 99, we're looking for 88 to 92. So quick quiz for you. With everything you've learned, and think about this for a little bit, but with everything you've learned, if you hook this patient up to capnography, what do you think their CO2 values would be? Low? High? Normal? So we're going to get right back to it, but I just wanted to tell you guys about our company called Sip and Scan. In the description, you'll find an Amazon link with coffee cups and a QR code. For $1.99 a month, every day you can scan this QR code and get a detailed, broken down National Registry question. Now, these aren't just give me questions or test preps. We actually dissect the verbiage of every National Registry question, and then we dig into the pathophysiologies and the why. You could check out a sample at Sip and Scan, or you can check out the link where you can purchase your own mug, but let's get back to it. A lot of people assume it's high because the patient has a lot of CO2, but keep in mind they got CO2 retention, which means they're not blowing it off. So whatever equipment you have to measure that CO2, well, it's not picking up excessive amounts of CO2 because the problem is the CO2 is stuck in the body. So most of these patients will have normal or maybe even low CO2 values. That doesn't mean the CO2 in their blood is low. It just means that it's not making it to the equipment we use to measure it. So let's talk about some other treatments, right? So we got the sympathetic nervous system and the parasympathetic nervous system, and they're both talking to those bronchioles, right? And the sympathetic nervous system is screaming, dilate, get bigger, I need oxygen. And the parasympathetic is saying constrict, get smaller, I need to rest and digest. And in you and me right now, both systems are talking to our bronchioles. It's not that one is off and one is on. The bronchioles just kind of find the middle ground between the sympathetic and the parasympathetic. Now, when we administer medications like albuterol, what we're doing is we're making that sympathetic nervous system louder, which is telling the bronchioles to dilate. So the bronchioles start to dilate. And then there's atrovent or ipotropium. And what that's doing is just telling the parasympathetic to be quiet. So you can think of a car rolling down a hill. Well, the albuterol is pushing on the gas and the atrovent is letting off of the brake. And the other common treatments are CPAP and BiPAP, but there's one little problem with CPAP, and it's not bad. It can help these patients, but it's not as good as BiPAP, and I'll explain why. You see, CPAP does a great job pushing air. It's continuous positive airway pressure, so it's pushing air down into those alveoli. But as the patient breathes out, they now have to breathe out against that pressure. And remember, we got CO2 stuck in the alveoli. So they breathe in air, but it's not all available for gas exchange, and they don't get rid of much CO2. The difference with BiPAP is BiPAP will actually decrease the pressure during the exhalation phase. Now, for every breath they take, the BiPAP pushes extra air into the lungs, and then when that pressure drops, well, CO2 escapes with it. So BiPAP forces oxygen and helps get rid of the CO2, while CPAP just kind of forces that oxygen down into the tissue. Now, another common medication we give is Salumedrol. Now, most of the time, unless you have really long transport times, you're not going to get to see this work. But that doesn't mean that it doesn't work for the patient. And just because the patient doesn't get better in front of you doesn't mean that we shouldn't be administering it. What it does mean is we shouldn't be administering it before the medications that'll help right away, like albuterol and atrovent and oxygen. So how Salumedrol work? Well, it locks those macrophages up, and that gives those cytokines some time to clear out. And it actually allows the alveoli to become a little bit more elastic, and it decreases the inflammation, kind of restoring the lungs back to their normal function. And then we have mag sulfate, relatively new, but what it does is it prevents calcium from getting into the cells, and that smooth muscle around those bronchioles, well, they need calcium to be able to contract. And the mag sulfate prevents that calcium from working its way into the cell.
This is me.
This is YouTube. And this is my channel. This is you liking and subscribing so YouTube knows who to show the channel to.